Now?
Absolutely wonderful.
All right. So, whosoever doesn't know Dr. S.K. Prasher, I think probably can leave the probe. He has been doing echocardiography for last 60 years. And obviously, I was in pre-nursery at that time. And he is a senior consultant in Metro Hospital and Heart Institute, New Delhi. And he is the person who had a conviction to start Indian Academy of Echocardiography. He pioneered it, and he is our patron, the president, and almost everything of Indian Academy of Echocardiography. He's been awarded with the lifetime achievement awards of from Indian Academy of Echo, from IMA, the World Federation, and distinguished physicians. He's authored a couple of books, which includes a comprehensive textbook of cardiology, and he's been delivering orations and talks all across the world as an international faculty, and he's a recipient of Government Health Ministry State Award. Uh, Dr. Prasher, please go ahead with your talk, and he would be talking about mitral stenosis.
Can you see my slides?
Yes, sir. All good.
Okay. Okay. Thank you, Dr. UP Singh, for giving such unwanted introduction and introducing us also. Now, I'll be discussing some common aspects because mitral stenosis is very well known to all of you. And most of you are also doing an echo of mitral stenosis. So we'll be discussing something basic and something also advanced what you should like to know. And because everything cannot be covered, so rest can be discussed during any discussion stage or during actually the question answer. Now remember in every echocardiography, there are three basic components. A clinical information, extremely important. Do not jump directly to echo. Start with a history, physical examination, ECG, etc. to get a general idea. After the clinical information, you don't neglect a 2D echo. A 2D echo gives you a complete anatomic information and almost semi-quantitative idea of severity. For example, suppose you see a markedly calcified aortic wall, significant LVH, other things that give you a hint that it is a severe aortic stenosis. So always see a detailed a 2D examination followed by a hemodynamic information which is given by a Doppler and which helps you in getting a more of a complete quantitative idea. Now, some important mantras of stenotic lesions are combine all 2D and Doppler data. In every echo, irrespective whether it is stenotic or not, the sequence is always 2D echo, color flow mapping, and then Doppler. This is in every echo. Always try to get maximum velocities because all your gradients according to the Bernoulli equation depends upon the velocities. If your velocity is wrong, all your calculations will be wrong. So always try to get maximum scan planes from where you can get a maximum velocity. Always before doing an echo, especially the stenotic lesions, see for any intercurrent illness. Suppose a patient comes to me with a fever, severe anemia, hypertension, or any other thing also tachycardia, we'll ask them to control this thing before coming again because many of these things will also affect our findings. So do not jump on our echo if there's any intercurrent illness. And as will also be pointed out by others, always record a heart and a blood pressure in your finding. Today you may be doing an echo at a certain blood pressure and heart rate. If after 6 months somebody does an echo with a different heart rate and BP, possibly the findings may be different. And always have an ECG, no echo without an ECG. Always see all the always the valves, not single valve also. And this is why we use the 2D. A 2D echo gives a complete anatomical and functional information. A colorful echo, a mapping gives you a direct visualization of blood flow and it guides you parallel to the flow, which is a basic requirement in a Doppler. So by seeing the blood, you can put your Doppler being parallel to it, and then a quantitative lesions can depend upon certain diseases on a peak and mean gradient, but a calculation of a valve area is extremely important because many of the other things can be variable, but this should we will always practice to do this and always be parallel to the flow. Now, there are so many things to be discussed in mitral stenosis, but because of time constraint, we cannot do it. We'll discuss some important aspects. A pathophysiology of every disease is very important. And you see in a mitral stenosis, there is a diastolic gradient between the LA and LV. Because the LA has to increase its pressure to push the blood against a narrow orifice. So basic problem is increased LA pressure, which later on leads to LA remodeling. Remodeling means a change in shape, size, and functions, and a persistent increase in the LAs can lead to an atrial fibrillation and LA clot. So this is a sort of a long-term affair because of patchy fibrosis. So this is one side of increased LA pressure. And when there's an increased LA pressure, the same pressure is transmitted to the pulmonary venous system, and this leads to a development of a pulmonary hypertension. And the RV is subjected to an ejection overload because the RV has to push luggage and increased after load. So the RV pressure increases and the patient develops RVH and sometimes it may fail. So we should not go up to this stage. So this is a basic pathophysiology based on an increased LA pressure, which occurs on both the sides or so. And coming to basic etiology and diagnosis. Now, remember for you, etiology is rheumatic, rheumatic, rheumatic. So that means a primary is the rheumatic or mitral stenosis, which is the most common and the important finding. The many of these findings, a commissural fusion is the predominant lesion, and the presence of a multivalvular involvement as always points to a rheumatic etiology. These things for example, this is a commissural fusion. These commissures are these places where the anterior and the posterior mitral leaflet come together at the annular insertion, and this leads to a fish mouth appearance. So this is the annulus, and this is the commissures which are fused in these cases. Then all other things you can know, all the thickening, calcification, and the paradoxical motion, all these things. And when there is a multivalvular involved, for example, here you see, now I keep my LV always on the left side. So you see there is a mitral stenosis, tricuspid stenosis, there is a turbulence across the tricuspid wall, leading to tricuspid stenosis and regurgitation. You see, this is the aortic or aortic turbulence leading to aortic stenosis and aortic regurgitation. So because of the presence of mitral one, that this multivalvular lesion also points to a rheumatic etiology. A secondary will be discussed mostly by Dr. UP Singh, but two important ones are there. This was an 86-year-old lady, comorbidities of obesity, obstructive sleep apnea, hypertension, diabetes, very minimal physical activity, and complained of shortness of breath. Now, this could have been contributed to many of these things or so, but an echo revealed a significant mitral annular calcification. You see, whole of this annulus is calcified, and this led to a presence of a turbulence known as a degenerative mitral stenosis. So this is the second most commonest we see usually in our country or so because of the mitral annular calcification. This extends to the base of the leaflets and the papillary muscles. And you see, and it has been shown that there's increased cardiovascular events in these cases. So do not ignore symptoms in the case of a mitral annular calcification, thinking it to be a normal phenomena. And you see, as the age increases, the incidence increases, but overall is about 12.5%. But this is the most common cause in a Western population because they don't see a rheumatic thing. Here you see 70 years, 10%, 80 years, 30%, 80, 60%. But overall, it is 12.5. And as I mentioned, it is mostly seen in Western population, and it is because of the effect of an increasing life expectancy and comorbidities, and the calcification extends up to the base of the mitral leaflets, Golgi and papillary muscles, and unfortunately, the management is very unsatisfactory in these cases. So keep this point in mind. Now, case number 2, this lady first reported to us in January 2005. Age at that time was 36 years. She had hypertension, CVA 3 years back. That means at the age of 33 years, she had a CVA with complete recovery. She had a clinically systolic murmur, and on basis of echo was diagnosed elsewhere as a case of a rheumatic valvular heart disease. But she was referred to us prior to MVR, and then we found that she had features of hypereosinophilic syndrome. I will show you the next slide. You can see there is an inferior-basal thickening, endocardial thickening, besides, of course, doming. But the most important factor was the zoomed apical view shows a marked fibrosis in the inflow region, very marked restriction of the movement of the posterior cusp, endomyocardial thickening and patchy fibrosis, and most important, the presence of an apical LV thrombus. So that means because of this and this, it was diagnosed as a hypertensive syndrome, and that was in a thrombotic stage, because this is the thrombotic stage, and this led to the presence of a cerebrovascular accident. Now, this was a young lady. You can see there is a doming of the leaflet. The mitral valve area was about 1.2. You can see 1.2 centimeters was the mitral valve area. Now, but when you went to the apical view, the gradients were markedly increased, 34 peak and 23 mean. And this gradient would not explain the presence of 1.2 centimeters square at the mitral valve area, which according to the previous definition used to fall in the moderate category. But on a CW, the mitral valve area by a PST was 0.8 centimeter. So this patient had a markedly increased gradients, significantly decreased mitral valve area on this, and then the normal and the increased mitral valve area on a planimetry. And you see there was a sort of an obstruction beyond the mitral valve. This flow acceleration, the flow acceleration is just below the mitral valve, and then there is a subvalvular a stenosis, which was giving rise to a whole clinical finding. So you can see there is marked subvalvular fibrosis. So that is why the mitral valve area was reduced on a pressure of time, but less reduced in these cases. So then some of the functional, the third is functional. These are usually transient hemodynamic mitral stenosis, and they regress after treatment. For example, you see there's a mass in the mitral lesion. This was a sort of a fungal endocarditis. And when this fungal endocarditis, it also moves distally into the mitral valve and will produce a transient obstruction. The same thing, another a myxoma, you see, going across the mitral valve in distally and will produce a sort of a transient obstruction. And these are transient because they decrease after the disappear after this treatment. This is an unconnected case. You see there's a right atrial myxoma, and when it hits again the tricuspid valve, it produces a functional tricuspid stenosis, and all these disappeared after the removal of the tumor. So these are some of the causes of this mitral stenosis also. Then we come to the diagnosis. All you know is that basically because of inflammatory process, every valve undergo thickening, fibrosis, and calcification. And the usual, according to our age group, is about 4 millimeters. So a point to note is that if you have to measure a thickness, you should measure at the tip of the leaflets and not at the body of the leaflets in the full distally, and that will tell you the thickness. Now, this, of course, this is always a doming. It shows a convexity toward the distal chamber, as you all see. Now, this is a very interesting study. Believe me, this is not the echo of those days. It was a paper presented in a British Heart Society meeting in 1976. That means 50 years back, and I attended that. Those were the days when this dramatic was not very well seen in United Kingdom, and there was no 2D echo, no color, no Doppler, and with great difficulty with it transduces we get a mitral wall. Now in a mitral wall, you see this is the A wave of the anterior leaflet, this is the A wave of the posterior leaflet. They move in the opposite direction. Now, at that time, the concept of the fusion of the leaflets was not there. And so the paper they presented was that in cases of mitral stenosis, both the A wave moves towards each other. That was this paper was accepted. And you see what they mentioned was, now this is of course a 2D guided, but it is not this. You see here the A wave of the posterior leaflet moves toward it. So this is the paradoxical motion of O of the posterior cusp. Now, how this helped us? Just now, this is one case we had few days back. There was doming of the mitral leaflet. You can see in the anterior mitral wall, it shows the doming, but no other features were present. And when we did the same thing, it was surprisingly, you see the A wave of the posterior leaflet and A wave of it, but move about the opposite direction. They do not move in the same direction. So we always felt that this is a non-dramatic, this is false positive doming, and this turned out to be because of a partially flailed mitral leaflet, and this was giving the appearance of a doming with eccentric MR. So just an incidental thing that all doming may not be pure stenosis. Then, of course, as wall narrow, this all you know, because in every stenotic lesion, there's an increased pressure in the feeding chamber. For example, in mitral stenosis, the feeding chamber is LA, so there's increased pressure leading to LA-LB gradient. In aortic stenosis, the feeding chamber is LV. In tricuspid stenosis, the feeding chamber is RA. So there's always a gradient between the feeding chamber and the receiving chamber. So this is because as the disease progresses, this will go on increasing. Now, severity, of course, you know, we are not going into the 2D echo. As I told you, 2D echo gives rise to a severity or so. For example, this is a calcified mitral wall, and as I told you, that a doming is a sign of mobility. But here there is hardly any doming because there is no mobility because of the calcified. Now, this gives us an impression that the MS should be severe. Now, one paper, I don't know, surprisingly, it said that one of the diagnostic significance is the distance the turbulent flow goes. Now, it is why the distance goes, the more severe the stenosis, the greater the LA pressure, and like a tricuspid regurgitation, the more distant the mitral, the turbulence and goes, and this is supposed to be more severe stenosis. Just an incidental finding. But the most important findings are MV planimetry area is the most accurate method for estimation, not affected by hemodynamics or any associated valvular lesions. And most of you are always already doing it in a short axis view. Zoom the image, and you go from the papillary muscles to all the mitral wall, and then you see this, and then you include the commissures in it. So some of the limitations are that you can find suboptimal imaging, atrial fibrillation. There is a very variable opening and closing. So you cannot get a perfect MBO unless you take several measurements. A highly fibrosed or calcified wall encroaches upon the mitral wall. It can be difficult. So that is why we always tell all our fellows that please practice. Even in a normal case, you practice how to calculate a mitral wall area. And these because when the limitation present, you will be most confused. So always practice it. That is important. And 3D echo is the gold standard as compared to 2D echo. It is the more accurate assessment of the mitral wall area. Imaging plane can be placed exactly parallel to the mitral orifice at tips. There is a better characterization of commissures and subvalvular apparatus, and it is a better in guiding various interventions. And you can see the whole of this mitral orifice, including the commissures also. So that is the, if you have got it, this is the best method as compared to the area. Then, of course, the pressure after you have been doing very, very confusing is the definition, but one I have added is the rate at which the falling LA pressure, when the diastole, when the mitral valve opens, the LA pressure decreases and the LV diastolic pressure increases. So the rate at which the falling LA pressure and increasing LV pressure come into equilibrium will be the pressure half time. So when there is a severe stenosis, it takes a longer time for the LA to empty into the LV and takes a longer time for the equilibrium to occur. So that is why the pressure half time is prolonged in severe stenosis. And automatically the machine gives you 220 by pressure half time. Your aim is to get a good Doppler envelope and just measure this thing and it will give you a correct area. For example, here you see it gives you the pressure of time and you see. And as mentioned in atrial fibrillation, measure always the long cardiac cycles that we will tell you just now. And these are some of the only those limitations which we see in our day-to-day practice. I'm only highlighting that. Not this, and believe me, these are the problems you will feel. Patients come with a sinus tachycardia. What we have seen, any heart rate above 100 beats, that's our calculation of the pressure half time and the mean gradients or so. So that is always the thing, and there's no time to reassure the patients or do what. So what we do is that we ask the patient to go back, take a beta blocker at night, small dose, a beta blocker next day, and come out 2 hours before. So see, there are variable complexes. No, you cannot do anything till you get this. And as you see the effect that, as I told you, this is not a good tracing. A tachycardia has an effect on a mean gradient because tachycardia reduces the diastolic filling time. And when the diastolic filling time is reduced, the LA pressure has to increase its pressure to fill the ventricles. And here you see the mean gradient about 13. And after beta log, it came down to 5. So that is why we always say, mention the heart rate because at that time it is very important. Second problem you always fail is a atrial fibrillation. There are variable complexes. Some are small, some are big and all that. The main thing to do in these cases is go on recording. Bound to be a complex will be a wide diastolic slope. It will always be there. Have a patience and take a patient with a wide diastolic. You cannot measure anything here, but here you see you can measure the wide diastolic slope and you can measure the peak and the mean gradient by plainly metering this, and you can see it by a pressure half time. So always do this. Then also you'll find in your daily practice what is known as a bimodal diastole. I'm only telling those things which you feel in a day-to-day practice. In these patients, initial is a very rapid down slope and then it stabilizes. Now, if you measure here, you'll give a very high area. Now, for example, here once you measured here, area was coming to almost 2.5 centimeters square because this is not the place to measure. When this was measured up in a mid diastolic area and did not go up to here, it was about 2. So the ideal way is that you do not measure here, take the mid portion where it stabilizes, go back, and this will give you a complete correct pressure half time, which was about 1.4 centimeters square. So these three things will be very commonly seen by all of you. And of course, the aortic regurgitation, And here, one thing I want to know, many times that the intervention cardiologists send the patient after even balloon valvotomy immediately to find out the mitral valve area. Please do not do a gradient because the mitral gradients or the mean gradient depend upon various factors like an MV pressure, LALV pressure, clampances also. So there are certain reasons and these all stabilize after 72 hours. So in those cases, never do a pressure gradient, but only take a mitral wall area. That will be more helpful to you rather than giving a pressure half time, which always varies according to these things also. Now you see, sometimes it's just an interesting slide. Sometimes you can see two jets across the mitral. Unfortunately, I don't have the apical view. Once you get two jets across the mitral wall, always measure the jet with the highest velocity. Don't measure the jet with the lowest velocity, with the highest velocity. Now this has come. This is an important slide. A low flow, low gradient severe MS like an aortic stenosis, when the mitral wall area is less than 1.5 centimeters square and the mean gradient less than 10, because as the mitral wall area goes on coming down, the mean gradient will go on increasing. But when the mean gradient is less than 10, but the stroke volume index is less, and as I told you, the gradient depends upon heart rate and stroke volume. So always and always the practice how to calculate the stroke volume. This will be also told to you by Dr. Srivastava. Always the practice. So here the low stroke volume is less than 35 ml. And it was found that those patients who had a low flow, low gradient, they were older, had more air, more subalveolar thickening, and decreased LV compliance, and they had a less symptomatic improvement after balloon mitral valvotomy because of these multiple comorbidities. So remember to practice it. For example, this was shown by a good study in which they found that low gradient mitral stenosis, their symptomatic relief is in 40% of cases it was less, and their of LA pressure and mean gradient was less as compared to those with had high gradient stenosis. So there are a lot of studies including in this also. So always when you find that the mismatch between your area and gradient, try to calculate the stroke volume. And they also found that those patients who had a low flow, low gradient volume, their survival was less as compared to those who had a normal flow and a low gradient. And it is very easy to calculate. You take the cross-sectional area of any structure and multiply it by the BTI of the LVOT, and the diameter can be converted into cross-sectional area by the formula diameter square into 0.785, and you take it with the BTI. So that the thing is, you take a cross-sectional area from the parasternal long axis view, diameter square into 0.785, and take a BTI LVOT from the apical long axis view so that you are parallel to the flow. That is the basic thing in any Doppler. And remember where you put your sample volume, it has to be a pulse Doppler. If you put very close to the aortic wall, it will be increased. If you put very distally, it will be decreased. Almost in the center, by moving the sample volume up and down and see where you can get the best tracing also. So try to measure stroke volume as a practice. And this, of course, this was previously what we used to follow, and this is after the ACCHA criteria, which showed that below 1.5 centimeters is severe and below 1.0 centimeters is very severe. Even if you see this, the most of the things they don't give a gradient now. Complication, of course, just interesting images so that you can see this, a mitral stenosis, there is a marked smoke, what is known as a spontaneous contrast echo. This is usually found in association with the atrial fibrillation when there is the blood components are very, very low moving in these cases, and when the ultra beams strike against them, they produce this sort of a mass thing. They are a precursor for a thrombus. Anytime you see a spontaneous contrast echo, you must look at thrombus, and every thrombus is associated with a spontaneous contrast echo. You see, again you see this is a multiple thrombi, you see a spontaneous contrast echo. You see again a transesophageal echo, spontaneous contrast echo, with a large thrombus coming and striking the mitral wall. So this is the must see the thrombus and the spontaneous contrast echo. Then you should always try to see a left atrial appendage. If you are lucky, you will get, but don't miss seeing the left atrial appendage from a short axis view. Here it is clear, but here you see there is a thrombus in the left atrial appendage. You see here it was completely clear, and here you see there is a spontaneous, there is a thrombus. Normally it is best seen from a T view, but if you are lucky and you can see some sort of a spontaneous contrast echo in LA. And then you can see in a small floating left atrial appendage thrombus. And this, of course, a Lutembacher, you can see this was the mitral stenosis with an ASD flow from left to right. And you see this mitral stenosis combination. Now, the Lutembacher can now be called any congenital or acquired ASD and mitral stenosis. So this patient had a balloon dilatation, and after balloon dilatation, you see they developed a large ASD, and this was known as the Lutembacher. And you see again complications remarked. Use the apical view, mitral wall, you can see multiple structures, like it was also a fungal endocarditis we see. So these are some of the complications which should always you see in these cases. Never forget to mention about commissures for two reasons. It tells you the etiology, and number two, whether they are fused or not. And you always see, for example, here, these are split. So they are unfit for any balloon mitral valvotomy. Here it may be possibly the patient had a balloon, but you have to see the various, any other features of this, it should be shown, or you, now you see here again, I told you, this is a commissure. Now, here you see this is open from this side. So possibly the patient might have undergone a mitral valvotomy, cannot say. And we can now do a commissure scoring. If it is calcified, we give you a 0 score because you cannot do anything. If it is non-calcified and not fused, that again it is 0, because if it is non-fused, you cannot do anything. And similarly, partially or extensively fused, the higher the commissure scoring, the better will be the result of a BM of a balloon. For example, here you see the presence of calcium in the commissure make the wall unsuitable for a balloon mitral valvotomy, but a overconfident cardiologist did this, and he developed a rupture. Then mitral leaflet produced torrential mitral flow. So you cured one disease and gave other big disease. You can see you could see this rupture here. Now, when do you do a esophageal echo? To detect LA clot, which is the best method to see, assess the severity of MR if present, to assess the valvular morphology and various other factors. And it is performed routinely before balloon mitral valvotomy in a patient of AF. And then you can see again a left atrial appendage and the presence of a contrast echo. So when you report, you have to give everything, whether the valve is balloon dilatation or not, by thickening, commissure, MR, and all these factors also. And you can see nowadays it is a sort of a good thing. All these things can be seen in this. So you can see a good result after a balloon mitral valvotomy and from an initial phase from here. So for the beginners, toming and wall thickness and pliability, parasternal long axis. Mitral orifice area, short axis view. Commissure, short axis view. Subvalvular apparatus, PLAX and apical views. Doppler studies, apical 4 and 3 chamber. In pulmonary hypertension, all multiple views, but 2 words of caution. This was one case, a short issue. Any structure behind the aorta is the left atrium. Patient had a severe MR and a TR, and a will record everything in its thing. So either you take any other view or you reduce the color angle, as soon as you see only the TR. So that is the thing, you don't see all. And that patient you see all the tricuspid regurgitation and mitral regurgitation toward each other. Now, if you take a TR jet velocity here, it will also interrogate the mitral wall jet velocity. Again, go to other views where MR is not seen, and here you see what would be there been effect. MR velocity about 89 and TR was about 33. So that was the difference. Illustrate, most studies are needed, they are done to see for various other factors. So always, whenever you give a report, always give all the features, whether to balloon, mitral valve, or not. All complete one, and by now you know what report to give. And always explain any unexplainable things. All this they have written below 100 and all these parameters, but any unexplained finding, for example, what we call as a high syndrome. Now see, this patient we got 17 years back, 2008, that is why you see the imaging. The patient was referred as a case of mild MS. But one thing which led to the, of course, there's mild MS, but one thing which was problematic, why the IBS is taken. In our daily practice, the four common causes of IBS thickening are hypertension, which were not present here, any hypertrophic cardiomyopathy, which were not there, aortic stenosis, and all this. So this gave us a hint that we are missing something. So we again went this, and then when we went again, we saw that the patient had a doming of the anterior of the aortic wall with a marked thickening of the interventricular septum. Then also, of course, this was a, and we also found that the patient had a tricuspid stenosis and regurgitation. You see, both the mitral and the tricuspid wall thickened and restricted to this. And again, you see a tricuspid stenosis and regurgitation, a severe tricuspid stenosis as per the various criteria. Also, the patient had an aortic stenosis and the regurgitation, you see, and a severe aortic stenosis and regurgitation. So that from one finding of an increased IBS thickening, you could see that the patient had a critical aortic stenosis and multiple lesions were present in these cases, which would have been missed if you had not followed the Y syndrome. Now, this is nothing to do with our case, just one last slide. Then you see this patient came, now he had a pericardial effusion, but why the RV is enlarged? Again, you see, there is a diastolic flattening of the interventricular septum. Why is this separate pathology? We could see that the patient had a anomaly. Yet these are aspects in a mitral stenosis, and I'm sure this can be discussed later on. Thank you very much.
Thank you, sir, for a wonderful and such an explanatory talk. There was one question which I would request you to answer. This is by Dr. Monica, who wants to know, is there any method to calculate tricuspid valve area with
See,
PHT method? Is it
yeah,
validated?
yeah, we always measure a sort of, as you see, the tricuspid area usually larger than that, but we normally still measure with a sort of as we do a mitral wall also, and that is less than one, or when here the mean graded is increased, the area is much less also. So we like a 3D may help you in measuring a tricuspid valve area. So much studies have been done on a tricuspid valve itself. But for at your level, it will be mostly again a Doppler-based technique.
Sir, I think you're absolutely right, because PHT cannot be, it's only reserved for
Yeah,
rheumatic mitral stenosis. It
yeah.
cannot be used in tricuspid valve, or not even in
Well,
mitral
same,
valve
yeah,
prosthesis.
same limitation, yes.
Yeah. So there is another question. The wanted to show the last case of dilated RV. What was the reason for dilated RV? That was one doctor is wanting to know. The last case
Okay.
they want to know what was the reason for RV
So,
dilatation. All right,
so
I
you
need to
see,
stop short. There was the Epstein. Yeah.
you see, and this was a tricuspid this Eastern anomaly.
Yes,
And
sir.
what we were seeing was the presence of a huge RA and this a sort of a atelized right ventricle. So this was the cause of in this patient same. You see here it was this coming like this. Again this. And so this was the cause for this
All
the illness anomaly was the cause for this massive right-sided thing also.
perfect, sir. Thank you very much, sir. If there is no more question, I think we'll move forward to my short presentation. I'll keep it very short and crisp, so for the sake of time. Uh, and okay, all right. So I would discuss a little more than mitral stenosis, which would include not only supramitral rings, subvalvular pathologies, but I would include the congenital LV inflow obstructions and the LV inflow obstructions and mitral ring. It could be a subvalvular apparatus problem, parachute mitral valve, hammock mitral valve. I'll show cases and cases of all varieties. Uh, and then pulmonary vein stenosis. So why don't we begin with pulmonary vein stenosis?
यही
All
रखो.
right. So now you see the pulmonary veins. Uh, Now in this patient, you see there is a flow acceleration in the pulmonary vein origin. You see the aliasing here, and you see there is a large atrial septal defect. But apart from that, there is aliasing in the pulmonary venous, and that was the pulmonary venous
क्यों?
origin obstruction. Can
हाँ,
you mute? Hmm.
हाँ. म्यूट तो कर दे.
And for young people, I just want to tell you how to take a Crab's view, or where we see all the pulmonary veins. The probe has to be right at the suprasternal area, and then should be positioned towards the chin. And this is what you see: all pulmonary veins in aorta, and then you see all pulmonary veins, upper and lower pulmonary veins in this view. And let me show you how does stenosis looks like in this view. You can see the pulmonary stenosis, lower pulmonary veins, and this pulmonary vein is showing an aliasing here. So that is a pulmonary origin stenosis. This patient had a severe RARV dilatation, and there was a severe pulmonary artery hypertension. So moving from pulmonary venous stenosis to the right atrium. Remember, right atrium is a kind of a membrane which divides the left atrium, and it is above the opening of the left atrial appendage. That's how you differentiate this from supramitral ring, which I am going to show you shortly. So this is a left atrial appendage opening. The absorption of the common pulmonary chamber embryologically is not happening into the left atrium, so that the pulmonary veins continue to drain in this common venous channel and then into the left atrium, and there is either restrictive or non-restrictive opening here. This is the chordatum sinister, and this is if you have the membrane or obstruction below the left atrial appendage opening. This is the supramitral ring, showing you example of both. And this is the patient with a large atrial septal defect. You see a non-restrictive membrane crossing the left atrium, and this is a chordatum. And apart from that, there was a large shunt between LV across the atrial septal defect. This is the fetal echo, and you can see on the fetal echo, this is right atrium and right ventricle were enlarged. The liver was there is a large effusion which indicated heart failure in the fetus. And once we did, there is some issue with there's some enlacing here, but let me show you in a clearer way. Okay, then this is a membrane. This is the left ventricle. This is the mitral valve, and that is the thick membrane. And this is the interatrial septum and fossa valis. And across this membrane, there was an increased velocities. This was the patient in the fetal echo of a chordatum sinister. So they've given a lot of classification for the chordatum, which is more of a theory. My intention is to show you cases, but let me proceed with the cases, and you can go through the classification online somewhere else. Supramitral ring. So difference between that, as I told you, is that this is below the opening of the left atrial appendage, and that is one again a fetal echo where I'm trying to show you a supramitral ring. You see this is just on the annulus of the mitral valve, and again on this view you just see it is right sticking on the mitral valve annulus. Intramitral ring, yes, obstruction can happen, which is the most difficult obstruction of the mitral valve you can imagine or see. Now, this is the patient where there is caught right rectum. There is small shelf here which is non-obstructing. There is something here you can see in between the valves, mitral valve, anterior and posterior leaflet. We let us zoom it and see it further, and there is an obstruction there. And this is the membrane. There is no obstruction for the caught right rectum, which is non-obstructive. So this patient had both chordatum, which is non-obstructive. Here you can see a very clear membrane which is holding both the mitral leaflets, and this is a intramitral ring. And zooming this again further, you can see very clearly right at the base of the mitral valve, this ring is attached, and this is an obstructive ring. The regurgitation is happening at the tip of the mitral valve, while the obstruction is happening at the level of the ring. Now, in the same patient, there was regurgitation, and this was again, I think, probably went back as then zooming the same patient. On the zoomed view, you can see regurgitation happening at the tip of the mitral valve, whether obstruction is actually happening here. This could be used as a clue. Regurgitation is happening elsewhere. Stenosis is happening little proximal to that. This was a wonderful 3D examination which we performed, and a very good clue what we had. You see this shelf-like structure below. This is right. This entire place is that mitral ring or a membrane. And interestingly, when we did from the ventricular side, when we saw, you do not see. Okay, and this is the tricuspid orifice, and that is the mitral orifice here. From the atrial side, you don't see anything. You don't see a valve because there is a membrane there, and beyond that, there is no visualization of the mitral valve. For the intramitral ring, how should you know, make an assessment? Now, this is mitral ring. The classic thing in a mitral valve is what we call as a mitral stenosis, we call as a doming. So once we have an intramitral ring, the doming doesn't happen because the leaflets are free and it's only holding the base of the. And now you notice here, there's no doming. This is severe mitral stenosis without doming of the mitral valve. Suspect intramitral ring, which is very difficult to pick up. So I'll skip the theory here and show you one or two more cases. This is what we call as an arcade or a hammock valve. And if you see, hammock is this, and this is an arcade. It depends upon the surgeon or a cardiologist which side you are viewing. You can either call it arcade or a hammock valve. The valves are thickened. This is the leaflet. This is about 4 years old male, and this is a case of a hammock or an arcade when the cordi are fused, and this is a severe mitral stenosis and regurgitation, a congenital mitral stenosis. This one can next is I'm going to show you the parachute mitral valve. In a normal valve, you have two papillary muscles. Both the leaflets, anterior and posterior, go to both papillary muscles actually, but once the anterior and posterior leaflets, they go to single papillary muscle. That is the hallmark of a diagnosis of a parachute valve. We There are again classifications which I would not go into details. What I just want to tell you that you have to have a single papillary muscle, and in case there are two papillary muscle, the other papillary muscle is rudimentary, then you call this condition as a parachute like mitral valve asymmetry. It's not a true parachute mitral valve. Showing you an example of a parachute mitral valve. Yes, you know it does look like a parachute. It does look like a parachute, and there is an obstruction of this parachute valve. This is the patient, the child with the tetralogy of fellows, and you can see this, the parachute here. This is a VSD, an aortic override, and you see this parachute valve here. And if you see this clearly, this is attached to the solitary medial, posteromedial papillary muscle to classify this as a parachute valve. I'm going to show you an example which doesn't fit in here, but this is a double orifice mitral valve. I am not going to show you double orifice mitral valve because this is we are talking about stenotic lesions. There are two openings of the valve from ventricular and atrial side. You can see what I am going to show you at the double orifice mitral valve with obstruction. Now, in this case, this orifice has not actually opened. You see this papillary muscle attached here. This orifice of a mitral valve has not opened. Only this orifice has opened, right? So the double orifice mitral valve with single, this orifice is atretic, and you can see this is papillary muscle here, and this is stenotic because single papillary muscle is attached to this part of the mitral valve. Technically, you might call this as a parachute valve because single valve is attached to this. Now you can see this part is atretic, and then you can see this is attached to the single papillary muscle. So this is double orifice mitral valve with the parachute on one side, and mitral valve with other orifice is atretic. Be cautioned that many a times you see many lax cordi, and don't jump to a diagnosis of a parachute valve. If you see the two papillary muscles, I think then you see the two papillary muscles, then this is not a parachute valve. These are just lax cordi, which are common in mitral valve prolapse and even otherwise. This was a patient where we had obstruction here. We were not sure what we are dealing with, and we had a mild mitral stenosis. But when we looked carefully, this is a congenital, this is a child of 3 years old, and you can see thickened papillary muscle. It's a kind of an arcade valve, and you see this thickened, hypertrophied papillary muscle, and this is a subvalvular pathology. Interestingly, these two papillary muscle were united by this band, which we call as the interpapillary muscle band, and that is seen so nicely interpapillary muscle band on a 3D echo. You can see this one papillary muscle, another papillary muscle. You see this interpapillary muscle. This doesn't produce any obstruction. Just wanted to show you this is just an marker that this is the papillary muscle abnormality which is leading to the LV inflow obstruction. Lutem-Becher syndrome, I'm not going to show you, sir has already shown you. The Lutem-Becher originally described when you should have a rheumatic mitral stenosis and an ASD. The ASD can be acquired, or that time the chance of ASD acquired was not there. Now there's a large ASD and the mitral stenosis. Remember, once you have a large ASD, blood from LA goes to the RA more frequently, less blood or cardiac output goes through LA and the mitral valve. You get small gradients even with severe mitral stenosis. So you can have a severe mitral stenosis, and behaves like a low flow, low gradient situation. And then the last one I'm showing you, this is again a rheumatic mitral stenosis, thick condoming, anterior leaflet moving anteriorly, and PML also moving anteriorly, and dilated RA and RV. And then this is severe stenosis of the mitral valve, and now you can see there is a large, there is not a very large ASD. This is a restrictive ASD, but this again would be qualified for Lutem-Becher syndrome. Thank you very much for your kind attention, and I think let me check in case there are any questions there. I would be ready to answer those. Let me unshare my screen first, and then move ahead. All right. So in the question box, let me see. Somebody said not able to see the slides of Dr. UP Singh. Was there a problem, Dr. Samir? Huh? No, I
No,
think
sir. From
I
my
think
side, there was
maybe,
no
yeah,
problem. I
yeah, maybe
could
there was
see
an internet connection, because
it well.
yeah, then one question is that significance of mitral ring. Yes, it is type of mitral stenosis, and needs to be corrected surgically. And pulmonary venous stenosis, uh, I don't think so. We have any classification for mild, moderate, or severe pulmonary stenosis. Uh, but pulmonary stenosis, if the velocities are high across the valve, across the orifice, is what we call it. And for this pulmonary, wanted to see pulmonary vein stenosis again, I think it's a good idea. You can go to my YouTube channel, EcoSing, and it's already there as one of the videos. Just browse it and you'll find out. So there's another all well, no problem. Show slides of chortritratum again. I think it's a good idea. You guys go to my YouTube channel, EcoSing, and I have about 98 videos uploaded there. And one of the videos is of the mitral stenosis. So you can browse and enjoy there. So let's proceed with the our next speaker. Dr. Shamish Srivastav, and let me introduce you guys to Dr. Samir. Okay. Yes.
Sir J, I'll introduce myself.
नहीं सर,
छोड़ दो.
कमाल है यार, नहीं इतना थोड़ी ना करना है, एडी मेहनत लगाई है चैट जीपीटी पे बैठ के। Okay. Now, Dr. Smear is a very, very good friend, and he is currently in a Max Hospital, Saket. He was initially in Fortis Escorts for a very long time. And he did his MBBS and MD and Mangalore and DM from Kanpur University. He has 3 decades plus experience in echocardiography, and he's an expert in transesophageal structural heart disease, three-dimensional echo, and he was a president of Indian Academy of Echocardiography 2018, and he had been editor of Cardiology Update 211, editor of Indian Heart Journal and Journal of Indian Academy of Echocardiography, and he got a Distinguished Service Award in the World Congress Award of Excellence presented by Delhi CM, and he is a member of a number of societies. Dr. Samir, yes, now you can go with your slides.
You'll have to stop sharing first.
I did, sir. Yeah, I didn't? 1 minute. I think I'm not sharing, sir.
You're still sharing, sir.
You still can see it? Huh? No, sir. Just try it, share.
Yeah, now it's off.
Yeah.
Okay, so I have divided my talk in 2 parts. One is how to look after a critical or a difficult aortic stenosis case, and second is some clinical relevance and what are the current understanding of aortic stenosis. So here I am, and 2 things I just want to start off saying that I am an attachment file to Dr. UP Singh, and whatever little of echo I have understood and learned is from Dr. Parashar. And it's always an honor and a privilege to be with him on the same platform. So, echo evaluation of a complex AS case. So, first and foremost is that not all cases of AS are difficult, but patience and adherence to protocols pay off. I'll quickly show you a few cases. Apparently normal looking LB. Convinced? Almost. What is the issue? Issue is that there is concentric left ventricular hypertrophy. You have auscultated, you have found a grade 3 murmur. You are not sure where it is arising from. You look at the apical continuous wave aortic valve, Doppler, and the max PG is 16. Mean PG is 10. But what are you doing? You are doing a protocolized echo, and this is what the GLS shows. Now, what are you dealing with? Cherry on top? Severe aortic stenosis, which you have missed? Amyloid with aortic stenosis, where you know that 1 in 8 patients of severe aortic stenosis have associated amyloidosis. So now you start hunting for an aortic stenosis. And when you start hunting, you have to look at least 5 windows. Parasternal long axis will give you a reasonably good idea whether you are dealing with a stenosed valve or whether there is a calcification or not. Then gradients can be picked up by 5-chamber, 3-chamber, suprasternal, epigastric, and right parasternal. So right parasternal is a little tricky view, but with practice you can get it. But never ever omit right parasternal in aortic stenosis. Best is to try right parasternal in every patient, because if you don't practice it, when you need it, you will not get it. So this is what we got in the same patient where the mean PG was 51, and this is what right parasternal views. So follow a protocolized aortic stenosis. Now, these are the two comparisons of apical and right parasternal. In apical view, your maximum PG was 16, and here the max PG was 71 with a mean PG of 31. Another view which comes in very handy is an epigastric view. So this is a story of an old lady with refractory heart failure. Apical window always showed a gradient not more than 25-30, but it never correlated with a clinical presentation. Anti-proBNPs were high, LV was normal, mean PG 26. So were we missing a severe aortic stenosis? Yes, because when you looked at it from a different window, it yielded the expected results of a severe aortic stenosis. Now here it is with a max PG of 68 and mean PG of 46. So here we are looking at technical problems which almost always are a reason for underestimating stenosis. These are the two comparisons when you look at the apical windows and the epigastric windows. Here the max PG in the apical window was 42. Here the mean max PG in epigastric view was 68 plus. 3DT is yet another place which comes in very handy. Parasternal long axis, the M mode, if you look at it, the box is reasonably opening well. But what you see is doming of aortic valve. If you look at it carefully, there is a systolic doming. And this systolic doming, if you see, is a diagnostic thing for any stenosis. If you see a diastolic doming in mitral valve, it is a mitral stenosis. If you see a systolic doming in aortic valve, it is a aortic stenosis. Now, you do gradients, you find it is a distorted anatomy. This distorted anatomy will keep failing you because you are not going to get the jet into the parallel line. And that's the reason why you have to trust and do something more. So here, so look at this. Here, the doming is more dramatic compared to what we were seeing. And here is a doming which you can see well. Not only that, there is an aortic regurgitation. So what we are dealing with is something which you have to figure out that what are we. So here is a stenotic aortic valve area, though the aortic valve area is not too bad, but you can utilize this as a area calculator. The advantage of 3D is that you can go at the right at the funnel of the tip of the funnel, and you can take axis which is right at the tip of the maximum stenosis. One more interesting case, post-CABG patient with severe LV dysfunction with recurrent hospitalization for heart failure. So clearly this is a poor LV. There is an aortic regurgitation, which is nothing dramatic. Short axis is consistently and clearly a very poor LV. Now what do you do? This is a 4-chamber view, globular heart, poor LV, global hypokinesia, nothing dramatic, more than 20% ejection fraction. I mean, if you are liberal, you will have 25% ejection fraction. Mitral annular calcification is there, but the mitral leaflets move very well. LA pressures are high, clearly so because the interatrial septum is bulging towards the right side. Now, look at the short axis. You don't get a very good short axis when the valve is calcific. This is at the baseline. It is clearly a tricommissural valve, but the valve area is 0.776. You don't know whether this 0.776 is a poorly opening valve because of poor cardiac output, or whether it is a distinct aortic stenosis. When you take LVOT gradient, you have a mean PG of 1, and the stroke volume is 66 ml. When you factor in this with the aortic valve gradient, your valve area is 1.1. So you are always plus minus. You are getting something by planimetry, something else by continuity equation. So what do you do? Okay, so this is what you did. This was our aortic assumption that this is severe aortic stenosis. Valve area by continuity equation was 1.1, which again doesn't qualify to be severe aortic stenosis. But we know that possibly that because of poor LV, you are recording falsely low gradients. So how do you sort this out? TEE, calcific valve. Unfortunately, you keep figuring out what it is. When you do a 3D for it, you have rubbish in, you will have rubbish out. Difficult to image aortic valves, calcific, differential, and this is what the 3D is, which is nothing more useful than rubbish. So what you do is a low dose vitamin stress echo. So whenever you are in conflict, that whether you should label this as a aortic stenosis, not aortic stenosis, or severity of aortic stenosis, best is to do a low dose vitamin stress echo in a poor LV. That is what we did. And when we calculated, our aortic valve area at rest was 1.1. And when we did a low dose vitamin, our aortic valve area reduced to 0.91. Gradients increased. And this is where we are. So we convinced the family. First, we had to convince ourselves. But once we had convinced ourselves, we subjected this patient to TAVR. And post TAVR, she did remarkably well. This is her PGs, which has gradients which have come to max PG 12 and mean PG 6 with an aortic valve area which was 1.85 or thereabout. And she did very well. Now coming to, I will stop sharing this screen. Okay, let me see. One more presentation I will make quickly, and then we can have some discussion about aortic stenosis. These are current understanding of aortic stenosis, that there are two problems. One is how severe aortic stenosis should be. When should you operate? When should you not operate? The controversy has even worsened in last 8 weeks. Asymptomatic severe aortic stenosis and low flow, low gradient. These are two concepts which I'm going to discuss in next maybe 10 minutes or so. Indications for valve replacements are completely well defined by the American Society of Echo and American Heart Association and the European. So the top ones are the American recommendations and the bottom ones are the European recommendations. Both clearly say that if symptoms are there in a aortic valve stenosis, regardless of whether it is moderate or severe, mild, certainly you don't expect to find symptoms. You must subject the patient for valve replacement. Second is hypotension. If there is somebody who develops hypotension on exercise, it is a class 2A indication. Now, what is hypotension? First, what are symptoms determined? Symptoms are determined by everybody has symptoms on stress test. But in case you develop symptoms in lesser than 5 METs of exercise without stenosis, you are pretty much sure that it is a significant aortic stenosis. And you must be very clear that they are not arising from lungs or any other way. What level of exercise? 5 METs. 5 METs roughly corresponds to about 4 minutes of Bruce protocol or 5 minutes of Bruce protocol. Second is, how is hypotension defined on exercise? This is a little tricky because all of us, when we say hypotension on exercise, we mean on exercise there is a fall of blood pressure. No, it is failure to increase blood pressure by at least 20 millimeters of mercury. If there is a fall of blood pressure, certainly it is hypotensive response. But in case the blood pressure does not increase more than 20 millimeters of mercury on treadmill, you call it as a hypotensive response. Now, once we have decided that the person has got excellent effort tolerance, patient is asymptomatic, he has got severe aortic stenosis, should you undergo AVR or not? Because now you have defined that they are really asymptomatic. Where does the data say? So this is an example of an elderly gentleman, 80 years old, asymptomatic, mitral annular calcification, some bed, severe aortic stenosis. You do a Doppler, the Vmax is 4.6, mean PG is 52 millimeters of mercury, and aortic valve area by continuity is 0.7 centimeters square. Fortunately, Fortunately, the definitions for severe aortic stenosis across the Atlantic have been settled. Earlier, there was a big fight. The Europeans used to say that the mean gradient should be more than 50. The Americans continued with more than 40. Now, regardless of which side of Atlantic you are, more than 40 millimeters of mercury on mean PG and less than 1 centimeter square by aortic valve continuity equation, and max PG of more than 4 is defined as severe aortic stenosis. Our patient clearly is asymptomatic, and this asymptomatic patient is clearly having a severe aortic stenosis. Now, what do? Do you do a waitful watching, or you want more data, or you do a direct aortic valve replacement? Wait, because let him cross 90 years, let him develop symptoms, and then do a TAVR, or wait and do something else. So this is some data from Auto, where they said that the moment you get a Vmax more than 4, the survival starts truncating. Very interesting. Same thing duplicated by Rosenhack, same thing duplicated by Pelica, and same thing duplicated by Stewart. Rosenhack was a little more detailed because they did analysis of calcification of the aortic valve also. If with this, the calcification of aortic valve was moderate or severe, then their survival was even worse. With no or mild calcification, their survival was better. Not only that, they further classified with increasing gradients, the survival was worse. And that is the reason with current recommendation, if you have asymptomatic aortic stenosis and your Vmax is more than 5.5, you have all the reasons to operate, even if the patient is absolutely asymptomatic. Now, these are the management challenges. Why is it that you want to wait with asymptomatic severe aortic stenosis? Because asymptomatic aortic stenosis, as was thought in past, had survival which was as good as a normal human being or even a little worse, but the surgical risk outweighed the need for surgery, because the surgical risk was more compared to leaving them at a higher risk compared to the rest. So this is what the debate was. And by another friend of ours from US, Manipal graduate, was very bold. He didn't get this paper published in any of the cardiology journal, and it was actually accepted by only Annals of Thoracic Surgery. He said that severe aortic stenosis, the moment you define a severe aortic stenosis, they start dying quicker. And if you replace the valves, they will have better outcomes. This is what he said, that if you have severe aortic stenosis, good about 20% of the patients would be dead in the first 1 year or 9 months. Very interesting data. So Kang was another one. He said, no, they don't die so badly. So was Nestri, and so was Taniguchi. Taniguchi was little more aggressive, and what he did was that he took two group of patients. One he subjected to AVR, and another he followed them conservative, and he said that in asymptomatic severe aortic stenosis, doing an AVR, the survival is better. Very interesting, very interesting, because the protagonist and the antagonist in anything can debate either which ways. And when the debate started, it was very interesting. The protagonist of conservative line of therapy said that 31% of the patients who developed symptoms did not have an AVR, and 17 patients died because they didn't report back, despite the fact that they developed symptoms. So if they would have reported earlier, the survival would have been better for conservative arm, because the conservative arm has to be followed conservatively till they develop symptoms. The moment they develop symptoms, you have to operate upon them. Anyway, now where are the indications for valve replacement surgery in asymptomatic. If you look at the American College of Cardiology, it is 5 meters per meter square, or there is a rapid progression and low surgical risk. This is class 2B. And what is a rapid progression? 0.3 centimeters square constriction per annum. If it is more than that, then you can really push yourself hard, because class 2B indication is something like class 3. So we are looking at max PG more than 5 is a definite criteria for valve replacement. When it comes to European side, then they are a little more liberal and strict. Not liberal, but strict. They want a Vmax more than 5.5, which again is a class 2A indication, which is reasonably a good indication. Not only that, they said that see the valve calcification and rapid progression, this becomes a class 2A indication, and valve calcification has to be calculated by CT scan. Another recent included is marked elevation of BNP, which if it is more than 3 times the baseline, it is class 2A indication. Now, these are the indications for valve replacement, which we have discussed: severity of AS, severity of calcification, left ventricular function, and exercise response. Severity of calcification is by calculation with CT scan. Cutoff for women is 1274, and cutoff for men is more than 2065. Only for calcification. Like you do a calcium scoring for coronaries, you do a calcium scoring for aortic valve. If your calcium scoring for aortic valve for men is more than 2065, or for women it is more than 1274, it is a criteria of severity and need for aortic stenosis. BNP, like I said, if it is greater than 3 times the ratio, then it is a reasonable indication for valve replacement. There are certain newer biomarkers such as troponin I, GDF15, soluble ST, and anti-proBNP. They are there. Coming back to our few more examples: concentric LVH, aortic regurgitation, aortic stenosis. Here we have a mean PG of 79. Severe aortic stenosis, not so bad aortic regurgitation, but yes, what do you do? Introducing one more concept: low flow, low gradient, and severe aortic stenosis. So there are 2 types of low flow, low gradient, severe aortic stenosis. Low flow is, Dr. Parasha sir has already said that in case your left ventricular systolic volume index is lesser than 35, it is low flow. Low gradient obviously would be lesser than that. And severe aortic stenosis is something that you have severe aortic stenosis, but it is not manifesting in form of increased gradient, low gradients. So there are 2 types. One is with LV dysfunction. I have showed you an example earlier of that lady where we did the butamin stress echo, and we documented increase of gradient and fall of aortic valve area. And there is yet another, which is normal LV function. Now, this is a very peculiar thing to understand. Low flow, low gradient, severe AS, normal LV. How can that be possible? Yes, it is possible. This is known as paradoxical aortic stenosis, and this can happen in hypertension. Say, imagine your blood pressure is, say your LV pressure is, say 250, and your blood pressure is 180 or 190. Obviously, you will not, or 230 or whatever. If you bring down your blood pressure, the gradients will manifest better. So treat hypertension. Number 2, do a catheterization if needed. And third is document that it is a severe aortic stenosis by whatever way. Now, to give you a philosophy that why does this happen? Why does paradoxical AS happen? It happens because of 3 hypotheses. One is that the LV is so hypertrophied that it cannot accumulate so much of blood inside the LV cavity in diastole. So when you don't have too much of volume in the LV diastole, whatever volume is getting exited from even severe aortic stenosis will not evoke that much of a gradient. So this is the most favored. Second is hypertension. With higher hypertension, the equalization of LV systolic pressure and aortic systolic pressure is lesser, and that's the reason you underestimate aortic stenosis. Third is that, say prior, the ejection fraction was 70%. Now it is 55%. So this will manifest as low flow, low gradient, poor LV, because compared to the 70%, this is a poorer LV. These are all hypotheses, but yes, this condition exists. And how should you sort it out? Sort it out by doing GLS. In case you find that there is a GLS which is reduced, please treat it as a paradoxical AS until and unless proved otherwise. Do a calcium scoring, do a transesophageal echo, use a CT scan, do whatever, but document that it is a severe aortic stenosis, which is paradoxical. And lastly, you must have a good clinical acumen. So low flow, low gradient aortic stenosis, the indications for valve replacement are different for reduced EF and normal LV. If it is reduced EF, the Americans say do a dobutamine study and document Vmax more than 40, mean PG more than 40, or aortic valve area less than 1 square centimeter. The Europeans say that do a dobutamine stress echo and document a contractile reserve. Contractile reserve is increase of ejection fraction more than 20% from the baseline, or more than 7% absolute ejection fraction, which increases with dobutamine. Now, indications for valve replacement in low flow, low gradient with normal LV with severe AS is only if clinical, anatomical, and hemodynamic data support severe AS. This is from the American side. For European side, if it is a paradoxical AS, only after thorough confirmation of severe AS, you can do it. It's a class 2A indication, but fortunately or unfortunately, doing some things improves the the survival, but not really the survival benefit. The class of symptoms improves. These are the types of heart valves, many of them, but what is now available is TAVR. And when you doing TAVR, you must mention these things. You have to rule out a subaortic membrane. The distance of coronary ostia from base of aortic leaflet should be more than 10 millimeters. If you are able to document it on transesophageal, well and good. Otherwise, don't hesitate to do a CT scan. Large calcific valvular nodules or not. Highly calcific aorta should be mentioned, because porcine aorta is something which is you have to change your plan of game. Aortic root dimension should be less than 45 millimeters at the sinotubular junction. Very hypertrophied septum is, and calcium in the very hypertrophied septum is a bad prognostic indicator, because these are the patients who would need more often, their requirement for pacemaker is higher. Aortic annular size should be between 18 millimeters to 27, but now there are 29 millimeters of valves also available, though not yet readily acceptable by most. And we have lost our race compared to CT scan, because when it comes to these numbers, the sinus of valva sizes, the distance of coronary arteries, these are the places where actually we have lost the race compared to CT scan. And we are now into the process of gaining our rightful importance. And this is a new software for quantitative assessment of aortic root. What is needed is do a aortic root image with real-time 3D imaging, and just follow a few simple steps, and you get the results quickly, because then it gives you a reasonably good cast. And this cast, you can calculate the diameters, you can calculate the circumferences, you can calculate the areas. The only thing which dubiously cannot be seen is calcification quantification. Quantification of calcium is something which is a little bit of a tricky issue. Thank you very much for a patient listening. I would be very happy to take questions in case there are any.
Wonderful, Dr.
I'll
Sameer.
stop sharing my screen.
Yep. As usual, wonderful. For the audience, let me give. Many of you were unable to see couple of slides or wanted to repeat. What I'm going to do it. I'm going to put this entire recording. I'll try to do it on the YouTube channel and give you a private access to this. Whosoever has registered on this webinar. Now let's take a couple of questions for Dr. Samir. There is one question. Is there any role of passive leg raise test during a low flow DSE protocol? Dr. Monica wants to know.
Monica, intuitively, what your question is makes sense because what you're doing is that to an underfilled LV, you're the heart, you are pushing in more of blood, and intuitively, this if you're filling up the right side, it should come back from the lungs and go into the pulmonary circuit and come back into the LA and the LV. But actually, it has not been documented. So if intuitive sense in it, the science has not yet proven it. And at some point of time, we must try to prove before we start recommending this as a protocol. Another thing is that for poor LVs, I am very skeptical to do DSC and leg raising test because dobutamine is an ionodilator. And with inotropy, what you are doing is you are increasing the heart rate. With passive leg raising, you are increasing your venous rhythm. Both the things are actually uh, kind of contradictory, and possibly it can precipitate a failure just in case you are not careful. So I'm not too sure whether this can be a recommendation or a guideline to work with.
I
But
fully
yes,
agree with you,
intuitively,
sir.
what you are
Yeah, I fully agree with you because the issue is not with the preload in cases of LV dysfunction because of aortic stenosis or otherwise. The this leg raise would be useful in a diastolic dysfunction where there is a reduced preload and you want to increase the preload. Once you have an LV which is dilated and the your ejection fraction is low, preload is already high on the LV wall. So I think it may not be a very good idea. So next, again, she wants to know if there is a discrepancy in the cath-derived and gradient on a
if there is no
Doppler.
discrepancy,
Now, if there is no discrepancy in, that's what
no
right.
discrepancy.
Yeah, there's no discrepancy in cath-derived gradient and Doppler gradient for low flow, low gradient, severe AS with depressed EF, with cath unable to define high gradient. How do we explain this? Did
No,
you
no,
get
no,
the
no.
question?
Cath is not necessarily for gradients
Yeah,
only.
correct.
Cath is to find out hemodynamics. It is to find out the preload, afterload, SVR, several other things. So when I said cath, it was not necessarily to define the pullback trace from LV to aorta, though that is also to be done. But it was a detailed hemodynamic assessments when I talked about catheterization.
She wants again, I think, input from you, a repetition that how do we define critical AS? Should the peak velocity be more than 5 or indexed aortic valve area 0.6 centimeter per meter square?
So this discrepancy will continue to happen, sir. If the aortic valve area and the gradients may not necessarily match because continuity equation has its own discrepancies. Gradients have their own downsides. The only thing is that in case you have to really find out truthfulness, best is to find out the aortic valve area by several other ways, which includes transesophageal echo and planimetry. And most important is your clinical judgment will never fail you. This is my uh, take home for aortic stenosis is if you're convinced that the person has symptoms because of aortic stenosis, hunt for gradients. If you fail to get the gradients, hunt for planimetry area, hunt for calcium in the CT scan. Something will give you a clue that you are missing severe aortic stenosis. You see, jet is so dubious at times. It can be so erroneously non-parallel to your plane of interrogation of Doppler that if you get it, you are very comfortable. If you don't get it, then you keep struggling, and you may not necessarily depend entirely on the gradients. That is the biggest technical problem and fallacy because of which you underestimate aortic valve stenosis, because you intuitively are trained to think about gradients and aortic valve stenosis, which is probably not the best way to take a clinical decision.
Dr. Abhishek
Sir,
Mittal wants to know, I mean, he has a very valid point that if we have a deranged RFT or a CKD, and then obviously in this patients we can't do CTs for recognize finding out the aortic valve and certain things for a TAVR. So that T would be very useful, and he wants your inputs on that.
so absolutely, I'm with you. It's more often than not that you will have problems with kidney function tests, and these days. So let me give you one more input. MR is coming as a very strong point in favor of replacement for CT scan. And even though gadolinium is supposed to be a nephrosclerotic agent, most of the radiologists and people who are into clinical practice, they feel that it is much safer than doing a contrast CT scan. Number two, uh, there are a lot of times that we have been stuck with these, and then we trust our transesophageal echo, even though they may not be as accurate as CT scan, but we do it. All you need to do is find out what is the distance from baseline to your coronary heights. If it is more than 10, don't care too much about what the volumes of the sinus of Valsalva is, whether they are roomy, not roomy. When you flip it open, if your aortic valve, in case your coronary arteries are distanced, they won't cause a problem. And that is the only problem which you most of the times have.
Yeah, doctor wants to know how to find post-aortic Bental procedure on echo. Probably he wants to know how to follow up patients of Bental on echo.
Exactly like the way you do any prosthetic valve analysis. Bentals initially did not have tissue valves. Now Bentals have, what is Bental? Bental is a composite graft. It has a valve and there is an aortic root which is attached. And two, three things which additionally which are happening are that you button puncture it, and you transplant the coronary arteries into the ascending aorta. Many a times you separately change the ascending aorta and you separately change the valve without disturbing the coronary arteries. That is yet another thing. But you don't change your ways and means to calculate what is happening. The problem comes is that when you are negotiating in parasternal long axis, you're seeing a tubular structure, and all along the tubular structure, you are seeing some muck. If patient has fever, you are stuck. You are stuck and damned because you think that this is a para-aortic abscess. Aortic root abscess may not necessarily be aortic root abscess, because in Bentals, what they do is when they replace the aortic root, the loose tissue all around the aortic aorta is actually double-breasted. When it is double-breasted, it looks like a space which is all around the ascending root, which is a little tricky. But this is the only difference of imaging, as you see. But when it comes to imaging for the valve, you do exactly like you do for any other prosthetic valve. We can have another session on prosthetic valve evaluation, and we can discuss those issues at a later date.
Good idea, sir. Dr. Abhishek also wants to know that could you explain the pressure recovery phenomena common in aortic stenosis?
Pressure recovery phenomenon. So there were two scientists. One was called Bernoullis and another was Venturi. 70 years apart. came back with the same philosophy that high velocity evokes low pressure around.
Hmm.
So whenever you have a stenotic valve, especially if you have a dilated aortic root, the moment there is a, this is more often than not seen in prosthetic valves, that there is a central jet. This central jet has got convergence. This ascends up into the ascending aorta. At the peak or at the center, you put your Doppler and you find that velocity is not translating into gradients. Why? Because this is the place where you just don't record anything, and all you have to do is go a little distance, and this recovers. This is known as a pressure recovery phenomena. Fortunately, all the gradients these days when we take are with continuous wave. So when you take continuous wave, the maximum stenotic area where you don't expect to find, where you expect to find pressure absence is countered, because continuous wave will capture all the gradients which are there from line of interrogation from top to bottom. So this is, fortunately, it is better off, but this is a phenomena if you start using pulse repetitive frequency, which is pulse wave with high repetitive frequency. This is in between the continuous and the pulse wave that you can get it, so you can be fallaciously flawed.
Yeah, great. I think pressure recovery phenomena is a kind of an Achilles heel for, because many a times you get so high gradients which you don't normally expect to get, and this is because once the kinetic energy which is there because of the high speed is dissipated, and if you have small aortas than the large aorta, and then you can have a higher gradient, or certain prosthetic valves also, like George Shelley valve, where you can have right in the middle orifice you can have a higher gradients falsely documented. But I think that is a chapter in itself. We might discuss it sometime later. Thank you, Dr. Samir, for such a wonderful talk on aortic stenosis, and many doctors have thanked you, including Dr. Monica.
So
So,
what is happening is that when the jet is going, it gets splayed,
yes,
and all these worlds, they add on to each other. And this is the reason why, beyond the place where you get nil gradient, you start getting a higher gradients beyond,
absolutely.
because every world they keep adding to the gradients.
So I think I would present the last talk, and that is aortic stenosis. Again, I would discuss congenital abnormalities of aortic stenosis. We would discuss a subvalvular aortic stenosis, and it could be subaortic membrane, which I'll show you a case. Subaortic tunnel. Hook'em is a kind of a different thing. I don't, include that in subvalvular aortic stenosis. Technically, yes, it is a subaortic stenosis. We would not be discussing Hook'em. So I'm going to show you subaortic membrane. I would be showing you subaortic tunnel as well. So again, not going through the theory, one most important thing which we should recognize that we do in a subvalvular aortic stenosis, the values are little different than the valvular aortic stenosis. The guidelines say if the peak gradient is more than 50 and a mean gradient is more than 30, and a subvalvular aortic stenosis is a good idea to do the surgery. The reason being, the subaortic stenosis is actually going to damage the aortic valve, because the jet from the subaortic membrane is hitting and damaging the aortic valve. So I would show you the Sean complex also in one case. Begin with case one. It's a young male with a loud murmur and a systolic murmur in the parasternal area and showing a severe aortic stenosis as per the gradient goes. The gradient is more than 5.5. It's a meter per second. So then on a scanning, you can see a very distinctive clear membrane just below the aortic valve. This subaortic membrane, if you are lucky, you can see such a nice subaortic membrane, which usually is not the case. So when we have a subaortic membrane, you see the stenotic jet coming right below the aortic valve where the stenosis is. Again, in this, you see the aortic valve stenosis and mild regurgitation. And regurgitation of this aortic valve actually happens because of the damage of the aortic valve by the jet coming below the aortic valve from a subaortic membrane. Remember, once you have an aortic stenosis, many a time the subaortic membrane may not be very easily defined on an echocardiogram because of the poorer resolution occasionally, and then this formula or this trick might help. The trick is in an aortic stenosis, this is a five chamber view in an animated form. This is aortic valve which is doming, and you see a PISA at the aortic valve. And when the aortic valve closes, you see the regurgitation at the same level of the aortic stenosis. But it is not the case with the subaortic membrane. In the subaortic membrane, the PISA happens quite proximally and the AR happens little distal to the aorta. This kind of discordance can help you to make an assessment of a subaortic stenosis where the membrane may not be very clearly visualized. So I am going to take you from case to case, from cases where the subaortic membrane, I'm going to show you about 5 or 6 cases where subaortic membrane was very clearly seen and where subaortic membrane was not visualized. And this Doppler formula or a trick helped us make a diagnosis. Going back to the same case which I showed you before, this is the subaortic membrane. And if you see here on the color Doppler, I want to show you now where is the PISA happening. PISA is happening here. Now, if I take you forward and this the PISA, right? And what about aortic regurgitation? Now, aortic regurgitation is starting from here. PISA was here. Now, again, on this example, you see the PISA of aortic membrane is here, while the regurgitation is happening here. This is the membrane. This discrepancy really helps you to make an assessment of a subaortic membrane. Now, another case where the subaortic membrane was, kind of doubtful here in a parasternal long axis view, because it may be difficult to see here because you are actually perpendicular on the 2D, but you might be able to see subaortic membrane little better on a five chamber view or apical five chamber view. Now you see this subaortic membrane, you see this aortic valve, and again when you go and see the flows, now very interestingly you see the PISA happening somewhere here while the aortic valve is quite higher up. So that gives you a very nice clue that PISA is happening before this. Even if I had not seen this clearly, then you might make the diagnosis. For again in the same this case, the membrane is not seen very clearly. You just see the speck here and here, but once you put the color Doppler on, you see the PISA of AS happening here and regurgitation happening there. Another very interesting clue. Again, the same clue. The PISA and this thing are discordant for AS and for the aortic regurgitation. Presenting a case who is a 3 years male, asymptomatic, had a gradient across the valve. There was a class 2 to 3 murmur and the mild AS and AR. And if you do put the colored up, you see here, you have a difficulty even as a young boy, where the echo window is not very great, you have some difficulty in visualizing a subaortic membrane, but you do have a suspicion there's something wrong below the aortic valve. Here, you don't get that, plus minus. And on a color, on a 3D again, you see some ledge kind of thing on this side, nothing very conclusive on the 2D imaging, and you don't see anything on the parasternal long axis view. So this is where our formula really helps. Now you see this aortic, the PISA is happening quite proximal to the normal expected valve. And once you see on color Doppler here, there is usually regurgitation in most of the cases of subaortic membrane. You see this subaortic membrane, and then you see on further pursuit that the regurgitation is happening at a little higher level. Let me search it for you and show you. Yeah, this is where the regurgitation is happening, and while the stenosis is happening somewhere here. Okay. This is just out of curiosity. There is subaortic membrane. You see the gradient across this, and this is a very clear-cut subaortic membrane. You can see, and what you see on this is the subaortic membrane, and on 3D color Doppler, you see the elasing or PISA happening before the aortic valve, the whole contention, and that was something which is not as rare. The subaortic membrane, the PISA happening here, and then what you see here is a bicuspid type 1 bicuspid aortic valve, which is a pretty rare combination to have subaortic membrane and a bicuspid aortic valve. Less than 20 cases have been reported. So showing you another case of a subaortic membrane. And in this subaortic membrane, what you see here is that you see this is the subaortic membrane, and the jet is kind of directed toward the interventricular septum, which is already a kind of aneurysmal, either because of this jet or a VSD which was closed by the tricuspid valve. This kind of aneurysm is commonly seen in perimembranous VSDs closed by the intraatrial septum growth. But in this case, I suspect the jet is actually hitting this area and making it balloon out. And this is what you can see. It is ballooning in systole, and this is happening because of the subaortic membrane, and you see this area. So that was another case. Showing you one more case of subaortic membrane. Let me show you, look at the ventricular hypertrophy in this case of a subaortic membrane, and you see the subaortic membrane here, you see the subaortic membrane in this place, and you see the subaortic membrane, and in this patient the gradient was really very high. As I was telling you many a times, the subaortic membrane, the distance between the subaortic membrane and aortic valve is too short and small, and you can actually miss these kind of subaortic membranes. And this is the subaortic membrane just abutting the right coronary cusp. And here you see this is producing regurgitation and stenosis, And this is so close that many a times you can miss this and can make the diagnosis of aortic stenosis. Again, here you see the subaortic membrane. Remember that subaortic membrane you would see when the valve is opening. So when the valve is closed, they are all opposed together. When the valve opens, that is the time you happen to see this subaortic membrane, which would not open in systole. So I'm going to show you this subaortic problem last case where this is not a membrane, this is little thickened muscular septum, and this is not hypertrophied cardiomyopathy because it is happening just before the aortic valve, and rest of the left ventricular myocardium was fine. And this is again a kind of an obstruction. If you want to know what is the difference between the two as per the management is concerned, there is no difference. Surgeon has to remove this muscle instead of the membrane. Outcome and everything is exactly the same as that of a subaortic membrane. Quickly showing you a very unusual, uncommon, probably undocumented case of an obstruction in the LVOT. And if you see this, yeah, you see some jet here, some kind of a jet coming from here. And when I thought that this is subaortic membrane, but see the jet is coming from this place. It's not coming from that membrane. So this is probably it is. I thought that it could be coming from the anteroseptal ligament, which is very a common phenomena. The ligament is a kind of an accessory papillary muscle which is not attached by any chordae to any valve, either goes and attaches to the mitral aortic curtain or gets attached to the interventricular septum here. In this case, it's attached to the curtain, and you see some gradient, nothing very great, a gradient of about 2 meters. So it's more of a curiosity than any treatment urgency. And on a 3D, rather than seeing a linear ligament, there is a kind of a shelf, and in that shelf kind of a thing, you see this jet emerging, which is obviously of no clinical significance. It's just an imaging curiosity. Showing you a very, very interesting case on a fetal echo. And I understand that you don't do fetal echo regularly. And let me show you here. Three vessel trachea view is a very common view, what we fetal cardiologists use it. That's a pulmonary artery, and this is the aorta, and this is the ductus, and this is superior vena cava. And what you see here is that there is a continuous flow in the aorta, which is retrograde. It should go in this direction, but it is blue and it's going away, and it's continuous. Both systole and diastole, you get a continuous flow in aorta, which indicates that there is some aortic regurgitation which is happening. That's why there is a runoff there. And once we interrogated, the right ventricle was bad, the left ventricle was kind of pathetic, it's hardly moving, no ejection fraction. Now you see there is something here. As the topic was subaortic membrane today, I would not diverge away from this. This is a scarred papillary muscle, dilated left ventricle, dilated left atrium, and what we had in this patient was a subaortic membrane, which on an initial examination we didn't pick up, but on a close examination, zooming the area, we saw a subaortic membrane. What was happening? Subaortic membrane produced LV dysfunction, produced aortic valve abnormality and regurgitation, and now the regurgitation was coming from the aorta into the LV, producing that kind of a continuous flow. I'm going to show you a shown complex, and which you have to have three of the 5 or 6 parameters of obstructive lesions on the left side. It could be a supramitral ring. It could be a chordatum, it could be a parachute valve, it could be a subaortic stenosis, and it could be a coarctation of aorta. Any, in case you get three or more, this qualifies for a Schoen complex, and that's a fetal echo. I'm showing you. This is the parachute valve, mitral valve, and then you see this is an aorta, which is, there is a subaortic tunnel. This is a small aorta. Aortic valve is hypoplastic, and the LVOT is also small. So that makes two components: one parachute valve, and second component an aortic stenosis, both subaortic and aortic one. And this is again that three vessel trachea view. Pulmonary artery is flowing this side, and there is retrograde flow in the aorta region. There is an interruption of an aortic arch here, and this completes the shown complex. Just one or two slides on supravalvular aortic stenosis. It can be of this type, or a diaphragm type, or a diffuse hypoplasia. The problem with supravalvular aortic stenosis is very commonly associated with multiple genetic abnormalities, and which you should be careful about. And whenever you have a supravalvular aortic stenosis, genetic assessment is kind of mandatory. Before I jump to the supraaortic stenosis, out of curiosity, I'm showing you something which surprised me once I was imaging. Do you see some aortic valve, and on the aortic valve you see some cordy kind of stuff attaching to the aortic valve? Yes, this was the patient of a bicuspid aortic valve, aortic stenosis, and you see this kind of filamentous structures which was attached on the aorta. Again the same thing, and this was actually a bicuspid aortic valve. We did do the research on the paper, and we found these can be some web kind of fibrotic bands which are reported in the literature. In one patient, the catheter got stuck in one of those fibrotic bands, and they caused a severe aortic regurgitation by damaging the aortic valve. That was very uncommon stuff, but I'm showing you a patient with the kind of a tubular aortic stenosis starting from here. This is supravalvular. Aortic valve was normal. The sinus of valsalva is fine, and you just get aliasing right here in just above the sinotubular junction, and then you see this hourglass kind of an obstruction, and the velocities was about 3 meter per second. This is a supravalvular aortic stenosis. This patient had Williams syndrome on the genetic workup. Then there's another patient with supravalvular aortic stenosis, which was mild, and this is again the gradient across it, and you can see on a three-dimensional echo the flow across the hourglass obstruction. So thank you very much for attending this webinar. I hope it would be useful to you for your day-to-day echocardiography performance. We would come up next with the regurgitation lesions, where we would discuss mitral, aortic, and a tricuspid valve regurgitation. And I would again pitch in between with these interesting or rare cases. So anytime, in case you want, you can go to this YouTube channel. We try to ensure that if you missed this webinar, and uh, and we try to give you the recording of the webinar on the same channel. So let me take questions in case there are any. I think this last session was probably went either well understood or went overboard. I don't know. But there were no questions. So thank you very much, Dr. Samir. I hope you are still there. And we will close the session. Yes. Thank you, sir. Thank you very much.
Can one last quiz for the people?
Yes, sir. Please.
Can I share my screen?
Absolutely.
Because in case they are still awake, Let me just share quickly. One last this thing, and what is this? So this patient had come with A2P2 prolapse, and we were planning for mitra clip.
Hmm.
Am I audible?
Yes, sir, you are. Do you want me to answer or you want people to give a try?
I was just trying to assess whether they are sleeping or they are awake.
They are awake and they are wide awake, but this kind of structures are pretty uncommon to see. This is some kind of a fibrous band which is extending from the aortic valve. And I have seen in the literature this kind of subaortic membrane also has been reported. Was it a subaortic membrane?
So these are Lambel's excrescences, which can be very
Oh,
unusually long.
okay. They were free. They were not attached anywhere.
No,
Okay, okay.
to the mitral leaflets. So these the only problem is that they, when you look at patients of stroke,
Hmm.
they'll have more of Lambel's
Relevance.
excrescences. But when you follow
Absolutely.
up patients with Lambel's excrescences, they
Mm.
don't land up with stroke more often than what non-Lambel's excrescences would be. But
Wonderful.
certainly, we stopped the clip procedure for this, and this patient went for surgery.
I can
So
now
I
see it
just wanted
going,
to
collapsing right into the aorta and going back. It's lying kind of a long, no,
in and
yeah,
out of aortic
in
valve.
and out. I didn't see that first. Yeah, correct, correct. It's going in and out of the aorta. It's going back into
LVOT and
LV.
aorta,
Yeah,
ascending aorta.
absolutely. And systole, it's going right into the aorta. Wonderful case.
Correct. Chalo. Thank you
Wonderful,
very
sir.
much. I just wanted
Thank you,
people
sir.
to
Thank you
get
very much
awake.
for the kind that you spent so much of time, and I hope this was useful to our listeners, our doctor colleagues. And bye from now. Right, Doctor? Saab? Thank you very much.
Always a pleasure, sir.
Yeah,
Thank you.
thank you.
Neeraj has answered it correct. Lambles.
Oh, did? Okay. Wonderful.
Even Abhishek Mittal has said outtake excrescences.
For I was bad. Good. Very good.